Welcome to MedSimo Medicine Podcast. Today we're tackling a really critical area for anyone preparing for exams or seeing patients, aortic stenosis.
Yes, absolutely.
Think of this as your sort of rapid-fire review, extracting the must-know information. And guiding us through this important topic is a leading expert in the field.
Thanks for having me. I'm glad to be here to discuss aortic stenosis. It's definitely something we encounter often.
Fantastic. We're going to cover a lot, from those initial, silent stages of aortic stenosis right through to the key management strategies. We'll also be focusing on what you'll find on examination, how to differentiate it from other conditions you might encounter, the crucial investigations, and how we approach managing and following these patients.
Right.
Our aim is to provide a really clear and focused understanding of aortic stenosis for those of you in training or early practice.
Absolutely. And I think understanding its nuances, it really can significantly impact patient care. So shall we dive straight into the history?
Let's do it.
Okay. What's key to remember, I think, is that patients can be completely asymptomatic for a significant period.
Right. That asymptomatic phase can be quite misleading, can it?
It really can. Often until the stenosis becomes what we'd consider moderately severe. When the valve opening is significantly reduced.
And then symptoms start to appear. Angina is often one of the first things that comes to mind. Why does that develop?
Certainly. So as the aortic valve narrows, the left ventricle, it has to work much harder to eject blood.
Okay.
This increased effort leads to hypertrophy, a thickening of the left ventricular muscle. Now, this thicker muscle, it demands more oxygen.
Right, makes sense.
So during exertion, when the body's oxygen needs increase further, that narrowed valve simply can't deliver enough oxygenated blood to the heart muscle itself.
Oh, okay.
And that results in that characteristic tight retrosternal chest pain, sometimes radiating to the left arm and neck.
And that prognosis point you mentioned.
Yes, it's a critical point that once angina develops due to aortic stenosis, the prognosis takes a significant downturn. Average survival without intervention can be just, maybe 2-3 years. So you really need to think of angina as a serious red flag in this condition.
That's a stark reminder of the disease's progression. Syncope is another important symptom. What's the underlying reason for that?
Well, the primary mechanism behind syncope and aortic stenosis is a reduction in cardiac output.
Okay.
The severely narrowed valve restricts how much blood the heart can pump out, particularly during exercise when the body demands more. This can lead to, lightheadedness and actual fainting spells.
And like angina, the prognosis changes.
Similar to angina, yes. The onset of exertional syncope carries a graver prognosis. It's also important to distinguish syncope that occurs with exertion from syncope at rest.
Why is that?
Because syncope at rest might suggest other underlying cardiac issues. Things like transient ventricular tachycardia, maybe atrial fibrillation, or even AV block. Different causes, different management.
That distinction is crucial.
Okay.
And then we have the symptoms of heart failure. What are the key indicators we should be looking for in a patient's history there?
Right. Heart failure symptoms in the context of aortic stenosis include the typical signs you'd expect: paroxysmal nocturnal dyspnea.
That's sudden breathlessness waking people up at night.
Exactly. And orthopnea, difficulty breathing when lying flat. Plus, of course, dyspnea on exertion and just general shortness of breath.
And the implications if it gets to that stage.
If aortic stenosis progresses untreated to heart failure, the survival rates are, unfortunately, very poor.
So angina, syncope, and heart failure, that's often referred to as the classic triad, isn't it?
Exactly. The triad of chest pain, heart failure, and syncope is the classic symptomatic presentation of significant aortic stenosis.
Got it.
Patients might also report palpitations, a sensation of their heart racing or fluttering.
Anything else in the history?
Yes, it's vital to inquire about a history of rheumatic fever.
Ah, yes. Particularly important in certain regions.
Especially in individuals from or who have lived in developing countries, yes. Aortic stenosis can manifest, say, 5 to 10 years after an episode of rheumatic fever.
And it might not just be the aortic valve.
Correct. In those cases, both the aortic and mitral valves can often be affected, something to keep in mind.
That long-term consequence of rheumatic fever is a really important point. All right, so the history provides some strong indicators. What should we be looking for during the physical examination?
Okay, the physical exam findings in aortic stenosis are often quite telling. One of the first things you might appreciate is a small volume, slowly rising pulse, sometimes called parvus et tardus.
And why does that happen?
It occurs because the obstruction at the aortic valve, it just hinders the rapid ejection of blood from the left ventricle. It slows things down.
Okay, what about palpating the chest?
On palpation, you'll frequently find an undisplaced but forceful apex beat.
Forceful because of the hypertrophy.
Exactly. The left ventricle is hypertrophied due to the increased pressure it's working against, making the beat strong. But because there isn't usually significant volume overload in isolated AS, the apex isn't typically displaced laterally.
And you mentioned a double impulse sometimes.
Yes, a double impulse at the apex is less common, but you can feel it sometimes. When present, that second impulse can be due to the fourth heart sound, the S4.
Indicating a stiff ventricle.
Precisely. A stiff, hypertrophied left ventricle contracting against increased resistance. Or it can be due to a particularly forceful atrial contraction trying to push blood into that stiff ventricle.
And of course, the murmur. That's a key finding, right?
Absolutely. Even before listening, palpation of the chest and the aortic area might reveal a systolic thrill.
A vibration?
Yeah, palpable vibration caused by the turbulent blood flow across that narrowed valve.
And on auscultation.
On auscultation, you'll hear that classic ejection systolic murmur. It's characterized by a crescendo-decrescendo shape, sometimes described as diamond-shaped.
Like a wave building and receding.
Exactly. Now, interestingly, while generally a louder and longer murmur suggests more severe stenosis,
There's a catch.
there is. In very, very severe cases, the murmur can paradoxically become softer.
Why would that be?
It's because the obstruction is just so significant that very little blood is actually able to flow across the valve. Less flow means less turbulence and thus less sound.
That's a crucial point. So a soft murmur doesn't rule out severe disease.
Definitely not. And critically, this murmur typically radiates up to the carotid arteries in the neck. That's a key distinguishing feature.
That radiation to the carotids is a really important clue. What else should we listen for in the heart sounds? S2.
Yes. The second heart sound, S2, can also provide valuable information. The aortic component of S2A2, which signifies the closure of the aortic valve, it might become inaudible if the valve is heavily calcified and essentially immobile. However, if the valve leaflets still have some mobility, you might actually hear an ejection systolic click right after the first heart sound, S1.
And what about splitting of S2?
Right. In severe aortic stenosis, you might encounter a reversed splitting of the second heart sound.
Can you explain that?
Sure. Normally, the aortic valve closes just before the pulmonic valve, A, then P. But in severe stenosis, the struggling left ventricle takes much longer to eject blood.
So A2 is delayed.
Exactly. It's delayed enough that it closes after the pulmonic valve. So you hear P, then A, hence reversed splitting.
That's a very helpful breakdown of the examination findings. Now, how do we differentiate aortic stenosis from other conditions that might present with similar signs?
Good question. That's where the differential diagnosis comes in. A common one is aortic sclerosis.
That's that different.
Well, aortic sclerosis can produce a systolic murmur that sounds somewhat similar. However, crucially, in aortic sclerosis, the pulse volume will be normal, and the murmur typically doesn't radiate to the carotid arteries.
Okay, important distinctions. What else?
Hypertrophic cardiomyopathy, or HOCM. There, the outflow tract can be obstructed by the thickened septal muscle.
So that can also cause exertional symptoms.
Yes, and you might feel a double apical impulse, similar to what we sometimes see in AS. Then there are congenital forms.
Like subvalvular.
Right. Subvalvular aortic stenosis involves a fibrous ridge or diaphragm just below the aortic valve. And supravalvular AS is another congenital condition.
That's the one associated with Williams syndrome.
Exactly, often associated with Williams syndrome, which also typically includes intellectual disability and hypercalcemia.
And one more critical differential.
Absolutely crucial. Always consider myocardial infarction in the differential for exertional angina. Can't miss that.
Definitely. So the history and physical exam can raise strong suspicion. But what investigations do we rely on to confirm the diagnosis and, importantly, assess its severity?
Several diagnostic tools are essential here. A chest x-ray in the early stages might show a relatively normal-sized heart.
But changes elsewhere.
Possibly. You might see a prominent, dilated ascending aorta. That's due to post-stenotic dilatation turbulence hitting the aorta wall just past the valve. You might even see calcification of the aortic valve itself on the film sometimes.
And if heart failure has developed?
Then the CXR will show the typical signs: cardiomegaly, curly B lines indicating interstitial edema, maybe pleural effusions.
Okay. What about the ECG?
An electrocardiogram, or ECG, in severe aortic stenosis often shows evidence of left ventricular hypertrophy, LVH.
Specific criteria for that.
Yes, voltage criteria usually. And often you'll see a left ventricular strain pattern.
Which is?
That typically involves ST segment depression and T-wave inversion in the lateral leads like I, AVL, V5, and V6. It indicates significant pressure overload on that left ventricle.
And what's the sort of gold standard investigation for visualizing the valve itself?
That would undoubtedly be the 2D echocardiogram. It's incredibly valuable.
Why so valuable?
Because it allows us to directly visualize the aortic valve. We can assess its thickness, the degree of calcification, leaflet mobility.
It's how well it's opening.
Exactly. It can also demonstrate the left ventricular wall hypertrophy we talked about, and crucially, it allows us to quantify the pressure gradient across the valve and calculate the aortic valve area.
Which tells us the severity.
Precisely. Those are key measures of the severity of the stenosis. Things like peak velocity, mean gradient, and valve area.
What about cardiac catheterization? Is that still used much?
It was used more frequently in the past, but honestly, it's now rarely necessary just for diagnosing AS. The 2D echo provides such detailed and non-invasive information. Cath might still be needed for coronary assessment before surgery, though.
Right. So once we've diagnosed aortic stenosis, what investigations help us determine if a patient is a good candidate for surgery for valve replacement?
Okay, pre-surgery assessment. First, a full blood count is important.
To check for anemia.
Yes, check for and correct any significant anemia. Low hemoglobin can definitely worsen both heart failure symptoms and angina. We need the best oxygen carrying capacity possible.
Makes sense. What else?
Exercise stress testing. This is actually a valuable and generally safe investigation, even in asymptomatic patients with severe aortic stenosis, provided it's done carefully.
What does it tell us?
It helps us assess their true functional capacity and, importantly, identify any concerning symptoms or blood pressure responses during exercise that might suggest they aren't truly asymptomatic, functionally speaking.
Unmasking symptoms, essentially.
Exactly. And sometimes a transesophageal echocardiogram, or TE, might be performed.
For a closer look.
Yes, it gives a clearer view of the valve, especially if the transthoracic images aren't optimal. It's also very good for ruling out or diagnosing infective endocarditis, which absolutely needs to be treated before any valve surgery.
Good point. And how do we monitor patients after diagnosis and, if they undergo surgery, during the follow-up period?
Postoperatively, after valve replacement, a 2D echocardiogram is typically performed, usually before discharge or shortly after, to confirm the successful surgical correction and establish a new baseline for the prosthetic valve function.
And for ongoing follow-up, how often do they need checks?
Well, the frequency of follow-up, particularly with 2D echoes, really depends on the initial severity of the aortic stenosis or the type of prosthetic valve if replaced.
Can you give some general guidelines?
Sure. For, say, mild native valve AS, a yearly clinical exam and perhaps an echo every 5 years might be sufficient. For moderate AS, maybe an echo every couple of years.
And severe?
If the native valve stenosis is severe but asymptomatic, we recommend clinical examinations perhaps twice a year, and an echocardiogram maybe yearly or sooner if they develop any symptoms.
And once they're symptomatic or post-AVR?
Once symptomatic and awaiting intervention or after valve replacement, patients should have at least yearly clinical follow-up with echo frequency depending on the valve type and clinical status.
Are there any screening investigations we should consider for individuals who might be at higher risk of developing aortic stenosis in the first place?
Yes, that's a good point. 2D echocardiography can certainly be used to screen individuals who we know have an increased risk.
Such as?
People with a congenital bicuspid aortic valve, that's a big one, or those with a known history of rheumatic carditis.
And the goal of screening.
Regular screening in these groups can help detect early changes in the valve structure or function, monitor the valve area over time, and allow us to categorize the severity of the stenosis if it develops, potentially leading to earlier intervention if needed.
Right. So we've covered diagnosis and assessment pretty thoroughly. Let's move on to management. What's the general approach?
Okay, general management strategies. These really involve addressing any underlying conditions that can worsen aortic stenosis symptoms or increase risk.
Like the anemia we mentioned.
Exactly. Treating anemia is important as it can exacerbate heart failure and precipitate angina. Also, if infective endocarditis is present, it absolutely needs to be treated with appropriate antibiotics before any valve intervention.
What about antibiotic prophylaxis for IE? Is that routine?
Generally, no. Routine antibiotic prophylaxis against IV is not recommended anymore for most patients with native valve aortic stenosis just because they have it.
But there are exceptions.
Yes, it is indicated in specific high-risk scenarios. These include patients with prosthetic heart valves, anyone with a previous history of infective endocarditis, or those with certain complex, unrepaired congenital heart defects.
And for prosthetic valves, there's also anticoagulation.
Yes, patients with mechanical prosthetic heart valves require lifelong anticoagulation, usually with warfarin. Bioprosthetic valves typically don't require long-term anticoagulation unless there's another indication like AFib. And specific antibiotic prophylaxis is still needed for high-risk procedures in prosthetic valve patients.
Okay, and managing heart failure if it's present.
Of course. If heart failure is present concurrently, it needs standard medical management alongside addressing the aortic stenosis itself, although definitive treatment of the AS is usually the key.
Right. So when it comes to specific treatments for the aortic stenosis itself, what are the main options?
The definitive treatment for significant severe aortic stenosis is aortic valve replacement, or AVR. Traditionally surgically, SAVR, yes. But increasingly, especially in older or higher risk patients, it can be performed percutaneously via catheter, that's TAVR or TVI.
And the benefits?
AVR, whether SAVR or TAVR, has shown excellent outcomes, even in asymptomatic patients who meet certain high-risk criteria. And critically, it leads to significant symptomatic improvement and, most importantly, increased survival in patients who have developed those key symptoms: angina, dyspnea, or syncope.
Is there an age limit?
It's crucial to emphasize that there really isn't a strict upper age limit for aortic valve replacement anymore, especially with TAVR options. The decision is based more on overall frailty, comorbidities, and expected benefit, rather than just chronological age.
Like that's balloon valvotomy.
Percutaneous balloon aortic valvotomy. Well, its role has diminished significantly with the success of TAVR.
So not a long-term fix.
Right. No, it's generally considered a temporary palliative measure, perhaps to relieve severe symptoms in very sick patients who are not immediate candidates for AVR or TVR, maybe as a bridge to definitive therapy, or for palliation if replacement isn't an option. But the restenosis rate is very high.
Okay, that makes sense. Well, that brings us towards the end of this really comprehensive yet, I think, focused review of aortic stenosis. We've covered an awful lot, from the initial silent phase right through to those critical management strategies like valve replacement.
Yes, it's a condition with a clear progression, and understanding each stage is key.
I think this has provided a really clear and concise understanding of this important cardiac condition, especially, as we said, for those preparing for exams and navigating clinical practice.
I agree. I hope it's been helpful. Early recognition of symptoms and accurate assessment are just paramount in improving outcomes for these patients. Timely intervention really changes lives.
Absolutely. And as always, we have to remember to correlate all these findings with the individual patient sitting in front of you. Consider the broader clinical context, their wishes, their comorbidities.
Couldn't agree more. It's never just about the valve number.
Right. We encourage you listening to revisit any of these areas that sparked your interest or where you feel you'd like a deeper understanding. Thank you for lending us your ears today on MedSimo.
Thank you.
We look forward to exploring another important medical topic with you in our next session.